Hi, I'm Jim Metz. We're going to spend a little time here, in addition to the course you've just taken, on understanding high-resolution pulse oximetry. Let's talk about sleep apnea first. We'll draw a ring around it, and that's what people talk about first. But before sleep apnea, there is really airflow restriction, which leads to sleep apnea. And then as it progresses, it'll turn into hypoventilation many times, or it can turn into Cheyne-Stokes respiration. We're going to talk about those things very, very carefully in later slides. I feel this is a very important slide to understand. It's Dental Clinics of North America, 2012. Gilles Levine is one of the authors for this paper. And what you do is you start here at the top, and you'll see that the sympathetic nervous system ramps up to a crescendo, and the high point being the tallest blue bar. If you come down below that, you will see that the sleep arousal happens right at the crescendo of that. You also notice the bar below that, or the line below that's tachycardia. The heart increases because of the sympathetic nervous system, the release of epinephrine, norepinephrine. Below that, you'll see that the jaw increased jaw opening muscle activity. Those are the suprahyoids, infrahyoids, and you'll notice that they occur somewhat before the crescendo of the autonomic nervous system. You'll notice the blood pressure ramps up later on. It doesn't come first; it comes later, after essentially the event is passed. Below that, you'll see the RMMA, rhythmic mascatory muscle activity. Those are the masseter muscles left and right, and you'll notice that they tend to fire when you have the crescendo of the sympathetic nervous system. But the suprahyoids have already fired, and the masseters are opposing the suprahyoid and infrahyoids. What that does, it causes a sling to form that pulls the hyoid bone and the epiglottis forward and off the back of the throat, increasing the size of the airway. I would really recommend reading this paper or this chapter of the book in Dental Clinics of North America, 2012. High-resolution pulse oximetry, HRPO. It's a very overused term. The only one that I feel in the market today that's really what I consider to be high-resolution pulse oximetry is the Minolta 300i. It has a sampling frequency of 1 hertz, which means 1 time per second the heart rate is monitored. The high-resolution pulse oximetry also measures the SpO2 at this 1 hertz interval. And it measures it to something very, very important in that it measures it to the 0.1%. I'm going to show you a slide a little later on as to why that 0.1% becomes extremely important. But it goes to a 3-second averaging. In other words, every 3 seconds it's a rolling average. So when it gives a data point, it's actually considering that second and the 2 seconds previous to that. So you're not getting a true second-by-second indication, even with the 300i. Most oximeters are much worse, and like I said, the 300i seems to be the best on the market that I've tested. So for screening, Boring showed that the 300i was superior to the other 4 units tested based on the 0.1% resolution. That is an important point. And multiple testing is most repeatable with the high-resolution HRPO with Minolta 300i. Sampling frequency is important because apneas can occur in repetitively short times, every 30 to 70 seconds. Lower resolution can suppress or you won't see many of the events. And when the amplitude, the criteria of obstructive sleep apnea, it must ensure that the SpO2 maximum is reached before the onset of the next apnea. This all gets into definitions. In other words, you have to have an apnea, you have to have a 4% desaturation in the SpO2, and that must occur before the next apnea. So let's look at this, what that means. Here is the same person, same hand, and you'll notice that they're dramatically different. Same night, same person, same hand. What that is you'll notice that the one on the left showed that there's a lot more sleep apnea present than the one on the right. It also picked up cycling and cycling severity. It also picked up movement. The movement is very important because the 300i has an actigraph built in which records movement. It also records the slope of the graphs, and we'll talk about that in 2 slides. So if you look at this next one, you'll see the averaging. Averaging simply means you've got a high and a low, and it takes the average of those. And so it tends to smooth things out. The more the averaging, the smoother the line. So you want the least amount of averaging possible. And right now, like I said, that's 3 seconds. Same person, same hand. Again, this is what is the 3rd page of the high resolution pulse oximetry. The blue line is the SpO2, or the specific pressure of oxygen, and the green is the heart rate. If you look at them, just to look at the one on the right and the one on the left, you'll see some differences, but let's blow them up a little bit, and you'll see there's dramatic differences. If you notice, the one on the left has slopes and the one on the right is square graphs. That's really important because the pulse oximetry software cannot analyze a square graph, where it can analyze a slope to a curve. Here's what I'm talking about. Below in the blue is the classic signal for the sleep apneic event. It's called the sawtooth pattern. It goes down, down, up, down, down, up, down, down, up. That's classic obstructive sleep apnea. Well, what about that slope, the down, down part? Well, the oximeter is riddled with air, and it's a problem. The one is picked up by adding an actigraph and removing that air. And physicians don't like pulse oximetry because of the errors that it generates. And what the software has done is gone a long way of eliminating as much errors as possible in a pulse oximetry recording. The slope of that graph to the left has the desat resat just below that, must be physiologically possible. So the shape of that graph must be able to happen. If it drops too quickly, then we know that that's not a real desat, and it's just picking up movement, and this oximetry software will ignore it. So the graphing becomes very important as to determining the true nature of the desaturation as recorded in the SpO2. Well, let's talk about this a little bit. There are 4 boxes I visualize in the body. The first one is the lung compartment. The second is the arterial compartment. The third is the tissue compartment, and the 4th is the venous compartment. What makes that important is that the lung oxygenates the blood. It moves the arterial to the tissue to the venous, and then it circulates back around. So the arterial component to the blood is generally the most oxygenated portion, and that's what we're recording with pulse oximetry. When you start to see desaturations in the arterial component, it means the tissue and the venous compartment are out of oxygen, and that's where the body stores most of the available oxygen for the body, is within the tissue and the venous compartment. So when you see it not being able to keep up, it shows you that the tissue compartment and the venous compartment are depleted, which means that the apneic event is getting worse. So if you look at this, you'll see a apneic event of 6 and a desaturation of about 4.8% from about 94 down to 91. And then you'll see the cycling time is 13% and the cycling severity is, 13? Well, what that means, the first graph is actually the RDI. It measures the number of DSATs that are from 2 to 4% and the ones that are the greater than 4%, and then adds them up to create a RDI, which is the 6. The next graph, the second one, is the saturation baseline drift. What that, you might wonder why that's green. And it's green down to 88% because Medicare will pay for supplemental oxygen below 88%. That's the reason why that's done like that. So you get the patient's high is about a 96 and down to a 91, and so that's their range of oxygenation over the night. It's very important for the patient to lay still at the beginning of the night and not go to sleep for 5 minutes and allow the oximeter to gain a baseline. If they just go right to sleep, sometimes they never gain a baseline over the night. So if they put it on, lay quiet, and stay awake for 5 minutes, you will get a better baseline drift approximation than if they just go right to sleep. The third column is the cycling time. That's basically how much time the body is trying desperately to get air. It measures when the oxygen goes from low to high, low to high, low to high, low to high, over and over again. And so this one is, like I said, about, I think that's 19%. No, it's 13%. I can't see very well there. Now, the severity index is a little different. What that is when one event ends up piling on top of another. In other words, the patient desaturates and then desaturates before returning to baseline. That shows more severity. What I like to tell dentists is you should treat people within the greens. In other words, if they're green in the first column, second column, third column, and fourth column, that generally means that there is not significant apnea present. So let's take that same person though, and you got to be careful where you're measuring the oximetry. Remember what this graph looks like. This is the same person the next night, except he was at 10,500 feet of elevation, had 3 glasses of wine. You'll notice that the recording is dramatically different. He would require supplemental oxygen through Medicare, but that's because of the elevation change. And he's a 26 instead of, what was it, a 6. Cycling time is most of the night, severity is increased, and he's dropping down really very low overnight. So you must know what has happened each night. I really do recommend that you record 3 nights in a row rather than just one night, because if you're dealing with someone who drinks, they may not drink one night, they may not drink the second night, but almost for sure they'll drink the third night because they can't stand it. And you'll catch it and you'll see what the difference is. It'll let you see why your oximeters or why your appliance is not working sometimes. So what do we do? This is called the natural history of a generic disease. If you start off down to the onset of the disease, that could be ADHD with a child. As you move into detected by screening, that could be TMD, and clinical presentation of sleep apnea is further down the road. Now this is for any disease, not just sleep apnea. So the incidence of ADHD in a child, if the tonsils and adenoids are removed, about 80% of the kids' ADHD symptoms resolve pretty dramatically if they're of normal body weight. If they're heavy, sometimes the drop is not as significant, usually about a 20% remission of ADHD. So how many people are there? Well, there's a huge amount of undiagnosed people, and this is where dentistry comes in very strong, because we see patients on a regular basis and we can start to follow their patterns. We know them. We know if they had car accidents. We know they put on weight. And if you go back to the flip chart, which I did previous to this, it'll help you to screen through and find the people who are previously undiagnosed. It's a huge part of your practice. So what is a hypnogram? Well, a hypnogram is very simple. There's different stages to sleep. There's awake, that's the W. That's R is REM, N1, N2, N3. Well, those are on the top graph. Those are the 3 or 4 major sleep stages. REM is, people say, REM is a different state of being. You're neither asleep nor awake. The mind is incredibly active. And so you'll see the REM cycles in a normal patient are shorter toward the beginning of the night and start to occur about 100 minutes into the sleep cycle and get longer as the night goes on. The person wakes up seldom, and N3 or delta or slow wave sleep is present in this person. Now the top graph, usually that N3 sleep is more present in the beginning of the night than at the end of the night. This isn't exactly normal in this one. Let's talk about the graph below it. You'll see multiple awakenings during the night, and you'll notice that there's no delta or slow wave sleep. It's a little bit different. The REM's at the bottom here instead of being at the top, but you'll notice the awakenings are pretty significant, and the person is awake all night long, and they'll usually report to you that they're dreaming all night long. So when somebody's dreaming all night long, that's a bad thing. And the lack of delta or slow wave sleep means that the brain has not had time to defragment. There's been implications that this may be the reason for depression, may be the reason for memory loss and changes in memory. N3 is very important because that's when the brain cleans itself up at night. So the other part about it is your REM cycles are not normal on the bottom. And the idea that you get this highly fragmented sleep, the patient is going to be tired the next day. So let's go back. If we include tiredness and really get down to business on screening for obstructive sleep apnea or upper airway resistance patients, it's not 40 million. It's probably as high as 100 million people. They just did a survey of the firefighters here in Columbus, that's where I practice, and 40% of them had obstructive sleep apnea. What is obstructive sleep apnea? Well, usually I define it as the tongue falling against the back of the throat, but it could be the epiglottis. It could be, literally, it starts at the tip of the nose and goes down to the lung. Any obstruction along the way can inhibit airflow, and so that's what will cause apnea. Obstructive sleep apnea is generally considered to be the back of the tongue or epiglottis falling against the back. How many minutes did it take to fall asleep? It should be at least 5 minutes, and really 7 is more normal. If you do that, the pulse oximeter will gain a good baseline. And I talked about this earlier. And so falling asleep immediately, it sometimes gives an erroneous recording for the baseline drift. And again, below 88% is considered abnormal, and Medicare will pay. Patient slowness lie still, and it defines the range as we move along. I can't stress that enough. This is what a normal pattern looks like. You'll notice the oxygen is pretty straight, the heart rate is pretty calm, and there's no what we call cycling of the SpO2 or the oxygen levels of the blood. But what does sleep apnea look like? Well, this goes back to the sawtooth pattern that you notice. Now, if you look right after the patient went to sleep, you'll notice that the lines are very nice and straight after about an hour or 45 minutes of sleep, and then they go into the sleep apneic pattern after that. That patient was awake. They weren't asleep doing well. That's usually awake. One of the troubles with oximetry is it doesn't have a channel to know whether the patient is awake or asleep. But when you see it flat like this, you can just about bet that they're awake. And if you ask the patient, they'll verify that. So here's the sawtooth pattern that is so prevalent in obstructive sleep apnea cases. Drops down, 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 up, down, 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 up, and you'll see it over and over and over again all night long, every night. Now, what about morbid arousal failure? What that is they start to drop, And if you notice the illustration here, they don't recover before they go into another vent, and then they go into another vent and another vent. And this is what drives somebody very, very low, and in this case drives them right off the graph. Hypoventilation is different. You'll see kind of a wave pattern. You see how the SpO2 is kind of wavy on this one? Well, if you don't have an actigraph built into the oximeter and screen with a tenth of a percent, this hypoventilation pattern a lot of times will not be evident, because oximetry gets a drift to the baseline, but it's just part of the machine error. And with this one, when you get a drift, you know there's a true drift. Well, what causes that? Well, it's usually fat within the chest cavity, and the lungs just can't expand. So you take a big breath, and then you take the next breath is smaller, 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 smaller. So you'll see this roller coaster action. You also see it if somebody sleeps on their stomach, even if they're a fairly normal size. So I recommend everybody sleeping on their side, and if they can't stay on their side, ask them to wear a backpack to bed and fill it full of towels so they stay on their back. If they want to get on their stomach and you see this pattern, have them wear the backpack on their front, not on their back. So that's good. So this is what the hypoventilation looks like. The next one is this rhythmic pattern. It's called Cheyne-Stokes respiration. This is very similar to a thermostat on the wall in your house. And the thermostat regulates the temperature within the room. Well, the body regulates the amount of CO2 and the amount of oxygen. And when your thermostat stops working in your house, instead of keeping it at a nice 72 where it might go up to 73 and down to 71, but overnight it just stays in that little tight range. But if that same thermostat started going up to 80 and down to 60, now the average was 72, but it was very high and very low. That's really what the body does with Cheyne-Stokes, and that's what you're seeing here. It doesn't react properly to the CO2 and the SpO2 levels. This is what happens. It's an overdrive potential. And what happens, increased ability to drive at baseline is lost. And I use this kind of like a sleeping beside a railroad track. You buy one of these 3 or 4 houses, and for the first 2 or 3 months you go to sleep, and as soon as the train goes by you wake up. But after a while you get so you don't wake up. The body doesn't respond like it should. You've actually damaged the neurocircuitry. One more thing about this averaging time being such a problem. If you look here, this is 3 pulse oximeters. One has an averaging time of 3 seconds, one 6 seconds, and one 12 seconds. If you notice, there's a different graph for each one of them, and the 12 being the worst, but the most sensitive is the one with the 3-second averaging. And it most approaches physiologic levels. That's the reason why you need at maximum a 3 per second per 3-second averaging time in an oximeter. I would really rather it be at a half second, but that's really not available today, at least not anything but in research. So what we're doing is we're going back to this airflow restriction, the sleep apnea, and the Cheyne-Stokes, and hypoventilation. What we're trying to do is reverse all these. We're trying to take it back to airflow and then make it go away. This is a great paper by Avram Gold, and what you'll notice on Dr. Gold's paper is that if you have upper airway resistance, which means you really don't have sleep apnea, and then you get into the mild and moderate and then up to the severe, you'll notice that headache, irritable bowel, and many things occur, and bruxism occurs much more with upper airway resistance than occurs with severe sleep apnea. So realize that when you see a TMD patient or you see somebody with a lot of bruxism or headache, really consider this and screen them for upper airway resistance. Sleep disordered breathing. It's very important. The Wisconsin cohort study is it was almost 2,000 patients over an 18-year period of time. At baseline, what I found really interesting about the Wisconsin cohort study is that it shows an association to be independent of variables such as age, gender, habits, whatever, and alcohol. The baseline versus the blood pressure. So here are the statistics. If you have an AHI of 0.1 to 4.9 at baseline, you had a 42% greater odds of having hypertension at follow-up compared to those with no disordered events. In other words, a 0.1 was showing an increase in blood pressure. And that if you had between 5 and 14.9, which is mild, you had 2 times the chances of showing elevated blood pressure at 4 years. And if you had severe sleep apnea, the odds were 3 times. So the relationship with heart and apnea-hypopnea index is very real. Okay, let's show a patient with a small airway. This is what you see here. And you'll notice I'm going to draw a circle around it, and that airway is tiny. If you take a normal Ceph, and I have a protocol for that too, if you want it, you'll have to email me for it. But if you look at that and you put your thumb over the airway, you'll see that the airway is much smaller than your thumb. Your thumb, or 10 millimeters, is just about normal. This is a more normal airway on the left, and you'll see the difference between the two. The person on the right has a higher incidence of asthma, has a higher incidence of sleep disordered breathing, daytime sleepiness. Exercise-induced asthma is very common with this group. They have trouble with swallowing pills. They'll gag on impressions, all kinds of things from that. So this is one on the left and the one on the right. Now, we're talking about a patient who's had a lot of dentistry here, obviously. You see all the crowns and implants and whatever. And if you look at the airway, it doesn't look too bad, but it is deficient when it was tested. And so if you put a radiograph beside it where we've placed a Herbst appliance and moved the jaw forward about 7 millimeters, you'll notice that the airway is much larger, the patient's happier, and they're breathing well, and they got a result very similar to CPAP. This is what the Herbst looks like. I like it the best because you can stick your tongue out through the space all in front or all around. It's easy to adjust. You don't have to, with the little lines that are on it that go up and down, those are put on in an approximation of habitual occlusion, and instead of having to count the turns of the jack screw on the arm, you can just take a Bowley gauge and measure how far forward you're protruded, and both sides should be about the same. What's interesting is the bell curve. Appliances that are big and bulky will take care of the middle of the bell curve, but there's a lot of small women in typical racial types that really have difficulty with a bulky appliance, and they're not the middle of the bell curve, they're the two ends. So the idea of having a thin appliance that where the hardware stays away from the tongue, I feel is very important. This is what the high-resolution pulse oximeter looks like. This is the one from Minolta. This is one of their ads, and it's just what they show. This is the finger probe that I like the best. There are several different probes, and this one has been a little bit of a problem. Sometimes it'll make a person's finger sore overnight, but they can just move it from one finger to another. They don't need to leave it on that finger. You'll see the error, and you'll have no trouble knowing what's what. Here's some sample patients. This is becoming more important because of the relationship between automobile accidents and sleep apnea. And this is a study that was done by Schneider Trucking, and it showed an extreme decrease in both healthcare cost and accidents and whatever. It was about $6,500 per person reduction in healthcare costs if their apnea was controlled. I thought that was really very important. One thing about it too is the pulse oximeter. If you turn it on while they're in the office and record about 10 minutes, that gives a pretty good cardiac fingerprint. So this can't be moved on to somebody else, and you know that the person you gave it to got the oximeter. So what I wanted to show here was the error signal, and realize that the error signal is not an error of the machine. It is an error from the sleep. If someone flip-flops around in bed all night long, their error signal is going to be very high, but that's also indicating that there's a problem with their sleep. So when I see a high error signal, I'm always thinking there's a sleep problem. It's not that the machine did anything wrong or you did anything wrong. It's just the patient is flip-flopping around, and the oximeter is picking that up because of the actigraph and the way the algorithm works to graph the slope of the lines. Here's what is possible with a before and after on a pulse oximetry recording. We have a 22 RDI on the left, and it went to a 2 on the right. You can see that even the baseline drift improved dramatically. So the hypoventilation decreased very dramatically with an oral appliance, and you'll see that the cycling time is much reduced. It's almost down to nothing, and the cycling severity is nearly completely gone. And this is what the third page looks like of that report. The blue is the one above is before, the one below is after. The blue line is the SpO2, the green line is the heart rate, and you'll see a dramatic difference. You'll notice that there's a couple spikes in the lower one, but look in between the lines, in between the two graphs, and you'll see motion artifact errors. The body, the oximeter picked that up and eliminated it. It didn't consider it. So those two spikes are erroneous. The patient probably rolled over there. The other thing, if you go back up to the top graph, you'll see some lines underneath the SpO2, the blue line, and underneath the green, the heart rate. That's cycling. That's when the software has determined that the patient is cycling for the heart rate in green and for the oxygen or the SpO2 in blue. This is interesting, GERD. The gastric reflux. There's a lot that can be done with gastric reflux that you need to work with your gastroenterologist or an ENT to talk about that. I'm not going to go in that now, but I can just tell you the one on the right versus the one on the left is pre-treatment, the right is post-treatment. We did not change the adjustment of the oral appliance whatsoever. All we did was treat the gastric reflux, and you can see all the numbers improve pretty dramatically. This is a before and after on the GERD. You can see the heart rate is calmed, the SpO2 is in better shape. It's really important to understand gastric reflux, and that's something you need to spend a little time studying. TMD patients, typically they'll all be in the greens. They'll be green for the RDI, they'll be green in the baseline drift. Cycling time is usually close to green or green, and the cycling severity is green. So they're all in the greens. But look at the third page of this. You'll see that the heart rate is dramatically active, and that's not normal. I feel when you're looking at a TMD patient that has a heart rate of this amount of change overnight. They're going to be tired during the day. They're going to exhibit many of the symptoms that a sleep apnea shows, but yet they're not considered to be sleep apneic. You refer this to the sleep physician, and many times they'll just send it back and say they don't have sleep apnea. But look at that heart rate. It's really, really something. So when you go into calming the heart rate from one to another, it becomes very important. So this is an improved heart rate with that patient. This is a PSG or polysomnogram. You'll notice that on the left you'll see a PES, higher PES, P-E-S. PES is esophageal pressure. It's when it goes very negative. This is measuring the pressure inside the chest. Actually, they feed a little electrode in down below the epiglottis and record this pressure. And you'll see in the patient on the left that the esophageal pressure is dropping pretty dramatically for quite a while up to the time of the arousal. That's the massive amount of ink there on the left graph toward the right hand side. And you'll see the esophageal pressure drops way down and then goes way up, and that's an arousal where somebody cleared it. Now you'll also notice that on the EMG or electromyogram electrodes, which are the ones that are bracketed in red on the left, you'll notice that they're not very active. But take a look at the one on the right. You'll notice that those electrodes are very active, and they're incredibly active. But notice the esophageal pressure stays more consistent. It stays nearly perfect, honestly. So what is that? Well, that's a TMJ patient. The one on the right, the one on the left is a sleep apneic patient that has lost the ability to brux. I can talk to you more about that, but that's an important point. So don't overlook alcohol. Alcohol on the top, no alcohol on the bottom. You'll see dramatic differences. So when you're getting bad oximetry readings, be really careful that the patient is not taking anything that will numb their reflexes. I say that you shouldn't take anything at night that you wouldn't take to drive. So if sleeping pills, any of the medications, many times will influence your oximetry. And the 300i is accurate enough that it'll pick this stuff up and it'll drive you nuts until you figure it out. But you have to keep a careful history night to night on the patient and have them fill that out, and you'll see the difference night to night. Okay, now what's going on here? If you notice, the onset of sleep is here. But then, what about this? What about these two? Those are very big oxygen disturbances. SpO2 is really going a little crazy. You'll notice that it occurs about 89 minutes in. Well, that's REM. That's REM behavior. So when you have a problem in REM and not in the rest of the night, you must treat that REM, because it's been shown that REM problems are what drives blood pressure higher than even the other sleep stages of the night. I can give you that reference if you like. So anyway, it occurs about 90 to 100 minutes in, and you'll see it spike like that. Now that's a place where giving them a backpack and making sure they're not on their back is really important, because that's extremely helpful. Again, look at this. This is the same patient before and after, and that's elevation. So be careful of elevation. Be careful where the people are doing this. And people travel so much today. If they change elevation higher or lower, you're going to get a different recording, and ask them where they did the recording. So be careful of this, because it comes in as a 17, which is considered mild, moderate, right in there. But notice the severity on the far right, in the cycling severity index is almost maxed out on the right. Whenever you see that, this is a little beware. One, first thing is they're 17, they're all in the reds. They need to be a referral to a sleep physician. But trust that 17 is not truly a 17. When they have the PSG done, it's probably going to be more in the 40s. So that 17 is not mild. It really is. It really is most probably severe, and it's indicated because of the cycling severity on the far right. So basically, you need to work with a sleep physician and help you with the diagnosis of these patients, because as a dentist, we really should not be diagnosing. That's not our prerogative, and I really value the relationship I have with the sleep physicians that I have. So be careful of this and stay out of trouble and just work with somebody. Don't try to treat one of these on your own, and refer it immediately, and the patient will thank you for it. Now, what I do is when I see one of these, I talk to patients about it, and I talk to them about the difference between CPAP and an oral appliance. And so you can pretty much rest assured that many sleep physicians will not bring up an oral appliance. So this is your opportunity to bring up an oral appliance and say, we may be able to do something here. But then if you take on a case like this, then they need to go back to the sleep physician once you have it adjusted and have what's called a clearing study done. And the clearing study shows that you actually relieve the apnea to the satisfaction of the sleep physician. So you essentially have an initial study, and then you titrate the appliance, and then you get a clearing study on the end. After the initial study that shows that the patient has sleep apnea, the physician will write you a letter of medical necessity, and that's what will allow you to go ahead and treat. So this is a normal, all in the greens. And this is a lot of times as a TMD patient, but they'll have very similar symptoms. In the beginning, everybody should be referred. Be pretty honest. I'd be glad to talk to you more about this, but that's a problem. When they're exhibiting sleep apneic symptoms, they need to be diagnosed by a sleep physician. This is pretty indicative of sleep apnea. They're obstructive. They're in the mild to moderate range, and they'll do pretty well. Now, when you get high baseline drift, this is more indicating of hypoventilation. This is when they're dropping down like that. They're either at altitude, they've had quite a bit to drink, or they're sleeping on their stomach, or they're really obese, and you'll get this baseline drift. So then you need to figure that out. But again, this is where you need to work with a sleep physician. When you see that there's nothing on the saturation of the baseline drift, what that means is the second column doesn't even have a number in it. It means they probably went to sleep before the unit could calibrate itself, and it's a very severe apneic case, and it really is non-calculable for the oximeter. You see it's way off the graph everywhere, so don't worry about it. These things need to be referred. Don't try to figure it out. Just make the referral. And so the idea that if you look down here, the ODI levels, which is all that many oximeters give, it shows an ODI of only 10, which says it's barely even apnea. But if you look at the severity of the cycling severity index being so high and picking up a 17 as an RDI, this isn't mild. So when you're working with an inferior oximeter, be really careful. You can't be careful enough is really what it is. I would never consider working anything but the best monitoring equipment that I have. And to be honest, it's the Minolta 300i and patient safety software. I get nothing from either place, and I have no financial interest in either, but they are absolutely the best that I've been able to test. I really like it, and I use it to titrate my appliances. Well, thank you for listening. My name is Jim Metz, and this is my email address. Feel free to contact me if you have a question about all this. This is a quick, very quick hit, and there's a lot to learn, but it'll give you something to learn and to get this under your belt, and then we can talk more. Okay, thank you, and have fun.